Good morning. All right, appreciate the opportunity to be here this morning. So as you may or may not know, we are doing a mandatory training for all of our 2,400 employees on culture of safety in order to reduce the type of bad things that happen to patients which hurt or kill patients sometimes. And so what I want to do with the doctors and our allied health professionals is kind of a hybrid. I'm going to show you what we're teaching them for two purposes. One, so that you know what they're learning and how they're going to be responding to you as physicians and providers. Also for you as providers of care to help set the tone and lead, for the rest of the staff what culture of safety should look like. So this, as physicians and other clinicians, you probably know some of this. I think some of it will be eye-opening to you. We are recording this because for our medical staff and our allied health professionals, it's not mandatory, but we're going to attach it to reappointments. That every physician, every allied health professional will either need to, they probably won't choose this option, either watch me do this here presentation, or we're doing audio for them, so they can just put it in your car, but whatever they would, or they can actually go to a website and view this, but that's what's going to be attached to reappointment. At some point, if that doesn't go well, and we think it will, by the way, the medical staff and leadership is on board, we will probably ask it to become mandatory. But anyway, so this is what we're here today to discuss. So let's start off with, and all of you all are familiar with these stories. You all know about the patient who was down in Florida, or even patients who may have been around here. Basically, it's the wrong site surgery. This guy, Willie King, was down in Florida. He had gangrene in his right leg. Somehow they amputated his left leg, which of course meant they had to go and amputate the gangrene in his leg, so he left the hospital in a wheelchair as opposed to on crutches. You know about the lady at the Boston Globe reporter who got 4 times the dose of chemotherapy, which killed her, which of course the Boston Globe obviously wrote an article about that. Not good publicity for the hospital, but once again, bringing attention to the fact that these kind of things happen in our healthcare system. The baby up in the left upper corner, Josie King, is probably one of the most famous of all the stories of things going wrong. That's an 18-month-old baby who suffered 2nd and 3rd degree burns as she fell into a tub of hot water. She was taken to Johns Hopkins Pediatric Intensive Care. Johns Hopkins is a fine hospital, obviously. Somehow they fell behind on her fluids, which of course, as you all know, the number one thing you got to do when you're treating burn patients is make sure they get their fluids replaced, so that's why they die, not from infection and certainly not from pain. But really the most important part of the story is that when the mother came to see the baby was supposed to be discharged to go home, like in a couple of days, and she came one morning and noticed that the baby didn't look right, and so she brought it to the attention of the nurse. And the nurse brought it to the attention of the physicians. And so the physicians saying, well, according to our, this is the day of the paper charts, everything looks to be good, everything seems to be in order, she's going home soon, just tell the mother everything's all right. But everything wasn't all right. And she said, no, the baby don't look right. When you're dealing with parents, sometimes they get kind of, like my wife was nuts. So when she say the baby's sick, somebody got to do something. And so she said, no, tell those doctors who are doing the rounds, come see my baby right now, or else I go get them personally. And so they delivered that message, and the doctors did come, and they said the baby didn't look right. And what happened was the baby was relatively dehydrated. So somehow they fell behind on the fluids, but they corrected that. But then the next day she came, and the baby's looking pretty good. And the nurse came to get the baby some morphine for pain. And so Mrs. King said, well, wait a minute, I'm pretty sure they discontinued the pain medication. She's going home in a couple of days, and the baby's no longer in pain. And the nurse took a look at the chart and said, well, no, the doctors they didn't discontinue it. I'm supposed to give the baby the medication. So she gave the baby the injection of morphine, and the baby went to a cardiac arrest. And by the time Mr. King came up there after his wife called him to come see about things, the baby was dead. And so what happened was a couple of things. Well, the baby was still relatively dehydrated, trying to catch up on those fluids. So then when you compounded that with that narcotic drug, that collapsed her vascular system, and she died immediately. And so a couple of things went wrong. First of all, they had discontinued the pain medicine, by the way. Mrs. King was right. Somehow they hadn't been communicated between the doctor and the nurse. Secondly, well, Mrs. King was trying to tell them, I know my baby better than you do, but they wouldn't listen. They were blowing her off. So we learned, and that's where they developed with something we called Code H, Code Help, for patients who are not being listened to by their doctors, so they can get help to go beyond a physician who may not be paying attention or somehow may be distracted. And so, but she took this thing on the road. She went on radio, she was on TV shows, and when I was working at Advocate, we had about 2,000 people in the auditorium, and she was the featured speaker. I was the MC. And when she was telling that story, I mean, it was chilling. And at one point, she looked out in the audience of all these doctors, administrators, and she said, "You know what? She said, how could you people, kill my baby?" Now, this is about maybe 5-8 years ago. And she said, "What are you all going to do to make sure it doesn't happen to anybody else's baby?" As clinicians, you all know, people, when they have a traumatic event like that happen to them, the first thing on their mind is not getting money. The first thing on their mind is, what happened? Apologize, and what are you going to do to make sure it doesn't happen to anybody else? So in the spirit of that, part of what we do and what we're doing is making sure that we educate all of our employees and hopefully all of our medical staff so we can change our culture so it's much safer, so the kind of stuff that's happened to her and Willie King with his leg and all that, it won't happen, or will be less likely to happen here at our hospital. So let me just go tell you a story. So when I've been chief medical officer for about 5 years. I came here, and one of the first calls I got, not the first week, but one of the early calls in my career here was from the recovery room in surgery. And they say, "Dr. Davenport, something's gone wrong. We need you to come down here." And so I go down there to recovery room, and I said, "Well, what happened?" So, I talked to the doc, and apparently there was a 20-year-old patient who was there to have she was there for infertility, and he was going to open up her tube so she could get pregnant. And so what happened was, while he was doing a laparoscopic procedure, while he was in there, somehow he got himself kind of confused as to who he was working on, and he tied and burnt up with both tubes instead of doing the opposite. And so I said, "Well, Doc, we got to go tell the patient what happened here. Now, tell me how you're going to present this to her." And so we kind of rehearsed what he was going to say. And I said, "Well, okay." I said, "Well, if you want, I will go with you." And he did want me to go with him, so I did go with him. And so we went to recovery room, and there was a young lady, and her mother was with her. So it was a young lady who wanted to get pregnant, and the grandmother who wanted to be a grandmother. And the doctor was kind of shaky. I mean, the look in his eye was a difficult one, because he knew it was a difficult message he had to deliver, and he felt pretty bad about what happened. And so he told the lady and her mother what happened, and of course, after that, they just broke down, just crying, just hysterical. And he's sitting there looking at them, and I'm looking at them. It was nothing else for us to say. We just sat there in silence while we told them what happened to him. And then, and sometime later, I got another call, a different incident. Say, "Doc, something bad has happened here in the lab situation. We need you to come on down." And so I said, "Well, what happened?" She said, "Well, we have 2 patients had breast biopsies, and one of those patients has breast cancer, and one of them don't. But somehow we have mislabeled, and we don't know which is which here." I said, "Okay." So I said, "First of all, you got to call the surgeons, and they're going to have to let their patients know." And so, and then we have to call the patient. So we did those things, and we offered those individuals, say, "If you come back here to Methodist, we'll redo that procedure, and we'll do your biopsies and at no cost to you." How receptive do you all think they were to those offers? Yeah, they say, "You got to be kidding me." They say, "I'm going to come back to you after what you just did." Say, "Not only am I not coming back, I'm going somewhere else. I'm going to tell people what you did to me." That's what they said, and that's what they did. So, those type of things, I've kind of seen those things before in my role, and you've probably seen those things happen before as well. That just highlights why it's so important to have a culture of safety, because, those kind of things happen, and those things will happen, by the way. John Hopkins, quite frankly, John Hopkins, after that incident, they put in a special program for patient safety, and they're known as one of the safest hospital in America. And they also have a Josie King Foundation, by the way. That's what they to honor Mrs. King and the baby that they killed inadvertently. But my point is, the things that they learn and other hospitals across our country have learned and studied and done are certain specific techniques that we are teaching our employees, and that I do want to kind of introduce you to, just so you can be familiar with them, and you may be already. It shows that, as evidence has showed, that if people will do these things, it'll guarantee that you can reduce the likelihood of those type of terrible things happening by up to 80% within a couple of years. So that's our goal, to try to reduce the likelihood that people will die or be killed or have bad things happen to them, because we, as clinicians, make mistakes. We're human. And so there's never going to be a time when there's never going to be a bad thing happening. As physicians, as clinicians, y'all know that. I don't know about you. I never got sued in all my career as an intern. I was 25 years. And I'm telling you, I'm sure that's just by the grace of God. Did I make mistakes? Oh, you know I did. I knew when I made a mistake. And I'm like, wow. But it's the nature of being a business. If you're a doctor, you're a nurse, you're a PA, that stuff happens. You do the best you can, but you're not infallible. And so we all know that. So once again, this is a program designed to make us safer as an organization. So this is a real schematic showing how many harm events we've had here at Methodist Hospital. And so we started in 2011, and you see about 200 what we call adverse events. And this is what they look like in terms of the breakdown. You can see the biggest one is people falling and hurting themselves. And some people say, well, and that's called, these days we call that a never event. Realistically, I think we all know there's no such thing as a never event, but we know what the point is. If you have your mother, your grandmother, your wife in the hospital, and she falls and gets a subdural hematoma, you ain't gonna understand that, are you? And why should you? You're in the hospital, you're supposed to be safe. Don't tell me my mother fell and got a subdural hematoma. Don't call me and tell me my mother's got a stage 3, stage 4 decubitus ulcer that she didn't have when she came in the door, right? Lay people, physicians, what do we think? Neglect. And that's not necessarily the case, is it? Sometimes people with certain diseases going to break down no matter what you do, but average lay person thinking neglect. If that's your grandmama, that's your mother, you thinking neglect, right? You don't want to hear that. So these are the kind of things that we want to say, well, how can we prevent them as best we can? Catheter-associated UTIs, central line infections. When I talk to the employees, I explain to them, I say, you know what? When we as physicians and clinicians order something that goes into your body, and we're doing that to help the patient, whether it be a catheter, an IV, a central line, or if we put you on a vent. But we also realize that once we do that, we have invaded your body and we have automatically compromised your immune system, your ability to protect yourself. So once we put those things in you, we know that we have to protect you from harm until we get them things out of you. But that's a necessary part of what we do as clinicians when we're treating patients. But also, well, what are we doing to make sure we get them out before you get a central line infection, before you get a UTI, before you get a ventilator-associated pneumonia? So that's what we're kind of trying to promote in terms of reducing those numbers that you see on that board. So why do bad things happen? So I'm talking to clinicians, so I won't spend much time with this. You all kind of know. But so what we teach in our employees is that, this is what we call a Swiss cheese diagram. And what this is meant to demonstrate or illustrate is this is us, clinicians, doing something to a patient, like we're ordering some medication or whatever we're doing. And on the other side, this is some catastrophic event happening to that patient. But in between there are policies and procedures, there's our educational, there's our skill, those type of things. We have people to back us up, so there's barriers to us making mistakes because we're human, that's gonna happen. But this is what happens and why you hear stories like Josie King and people getting the wrong leg cut off, because every once in a while, this is what'll go wrong. So let's say this is Dr. Al Reynolds. Usually when I'm talking to employees, I use me, but since I got some fodder here, best you're sitting in the first row, I'm gonna pick on you. So theoretically, this is Dr. Al Reynolds. He's prescribing Lanoxin. I'm old school Lanoxin. He's prescribing 0.12 milligrams IV push because he's treating AFib or something. And so he writes down 125 milligrams. He forgets the decimal point, right? Those things happen. Of course, if he gives her 125 milligrams of IV push DIG, she's gonna be dead in about, 60 seconds, right? And so when Al does that, well, but there's his nurse, and his nurse saying, oh, Dr. Reynolds, that's crazy. You didn't mean that. She's protecting him. She's got his back. She's also protecting that patient from harm. But then what happens here? Okay, Al is still having a bad day, and this is nurse having a bad day. Oh, boom, but there's his pharmacist, see? The pharmacist is saying, oh, no, doc, I'm not gonna even send you that dose. They don't even exist. That's not what you meant. So we're protecting ourselves, protecting our patients. But as you all know, every once in a while, when the moon is full, there we go. We get past everybody and boom, we have killed Mrs. King's baby. We have misdiagnosed breast cancer. And so it happens rarely, but it happens when everything lines up crazy. So what we're trying to accomplish with our employees and with you as clinicians is to make sure, see, since we're human, those holes in the Swiss cheese, they're never going to go away. Impossible. But what we can do is we can make those holes smaller, and we can make them more difficult to get in line, so you won't have those rare events when you have those catastrophic things. So that's what we're trying to accomplish, and that's the theory of cultural safety and how you can reduce those errors. So why is error prevention and safety so important? I know that screen is dark, but I've given this lecture many times, so I know what's up there by heart. So the first bullet point says that 200,000 people die from preventable medical errors across our country every year. And so in 1999, the Institute of Medicine report came out. You may be familiar with it. And what did it say? It said that our research showed, by self-reporting, by the way, hospitals were reporting on themselves, it says that 99,000 people are dying every year from preventable medical errors across our country in our healthcare organizations. So back then, we as physicians were like, that's crazy. It ain't 99. That's not possible. Those many errors are happening that we're hurting people by preventable things. And apparently we were right. It's 200,000. So to put that in context, what does that mean? Well, that means that if you have a jumbo jet airliner that carries 750 people, that means if you take that airplane, it crashes and kills everybody on board, and that happens every day for a year, that's 200,000 people. And so when I talk to employees, I ask them, if that was happening, would you fly a plane? And of course, no. But the equivalent of those many people are dying in our country because of preventable and medical errors that are happening, in our hospitals and our other healthcare organizations. So I try to make sure that you understand the magnitude of the problem, which is why, of course, the government and various people in our society say, you know what, we don't tolerate airplanes crashing every day. We're not going to tolerate this either. And so one thing the government does things to try to motivate us to make it better, but they can't make it better. Only we can fix it, which is why we realize that we got to take this to the clinicians and everybody who works in the hospitals, because only we can make this a better number than it is. Another bullet point up there is 99,000 people die every year from preventable infections, hospital-acquired infections. And so I asked the employees, and I asked you, so what's the most common thing we can do to help prevent that? And so let me ask you all, in our country, what do you think, what's the average percentage that healthcare professionals wash their hands before and after they see a patient? What do you think the national average is? Maybe you know. 15%, 1-5. It's 50%. At Methodist, it's 80%, by the way. So is that pretty good compared to the nation? So if your grandmother gets an infection because Richard didn't wash his hands, is that going to be acceptable to you? No. So my wife is a lawyer. More importantly, my wife is a layperson. So whenever I tell about these kind of things, leaving things in people's bodies, cutting the wrong leg, not washing our hands all the time, she looks at me like, well, how's that possible? That's how lay people think. They're like, so you're telling me that you don't wash your hands before and after the patient, and you know there's a risk that they can get an infection that could kill them, and you do that, why? How do you answer that kind of question? That's pretty much what juries think. They say, Doc, what does that mean? Nurse practitioner, what do you mean you don't have time to wash your hands? People don't get that, and why should they? I don't get it either. It's crazy. But that's the kind of stuff that we do. The other thing on this slide says that over 6.5 people, these are employees, per 1,000 get hurt or injured or sick on the job here at Methodist Hospital. So that's about 6. We got 2,000 employees, maybe 60 to 70 employees every year get sick or they get injured on the job. And so what I try to explain to the employees is this. You know what? The number one cause of injury at Methodist is needle sticks. Number 2, people hurting themselves pushing and lifting patients. Number 3, and you're going to be surprised to hear this, people slipping and falling and hurting themselves. That's the number 3 reason that we have people out of work here at Methodist. Okay? Slipping and falling and hurting themselves. And so when I talk to employees, I say, you know what, physicians, clinicians, we already know how dangerous it is to work in a hospital. And they need to understand how dangerous it is too. So my point is, I talk about patient safety. I say, but safety and the culture of safety is not just about the patient, because everybody knows, well, what's in it for me? So it's about keeping you safe too. And I explain to the employees what you all already know. If you get stuck by the needle, I'm testing you, and I may have to treat you for HIV, hepatitis B, hepatitis C. You may lose your liver. This is like no funny business. I try to make sure they understand how serious this is. I tell them about when I was an intern at Cook County Hospital, and that was way back in the day, how we would pump in chests and blow on people's mouths and saving lives. And this time this patient came in was having some alcohol withdrawal seizures. So he went into cardiac arrest. So me and my senior resident, man, we go into action. We like on TV, and it was like, this is good stuff. But after that, the chest X-ray showed 4-minute pulmonary tuberculosis. My resident was blowing. I was pumping. He was taking INH and B6. I was not. And I'm like, ooh, this medicine thing is serious business. This stuff dangerous. We had a classmate at U of I who got infected by some blood and got hepatitis B and missed a whole semester of medical school. So we physicians and clinicians know how unsafe it can be to work in this setting. And I want to make sure that the employees get the idea, because you guys already y'all get it, right? Okay, these stories should be foreign to you. And so after I've kind of emphasized that, I talk about how important safety is, in terms of hospitals, and I'm the interim CEO, and so I'm looking at finances and growing our businesses and employees getting paid every 2 weeks, and of course as a physician I'm always going to be concerned about quality and safety, and as well as the patient experience with the Studer and the AIDED and all that kind of good stuff. But when I talk to the employees, I try to make sure they understand all that stuff don't mean nothing if we ain't safe. And I explain to them, I say, if you look at Toyota used to be the garbage car of the world. And they became #1. And they did what we call Lean Six Sigma, which means they reduced, they got down to almost 0 defects. Quality, value, 0 defect, that's Toyota. And that's great. But if something happened in the culture there and they lost focus of what was most important, next that accelerator started sticking, I said, you know what? You can't make no money doing that. Nothing's more important than safety. I make sure I explain to the employees, you know what? If you're having a nice conversation and giving the patient good service and you didn't know that Studer and AIDA stuff, and it's the wrong breast biopsy, you can't have a good patient experience. And I say, if you cut off the wrong leg, that's going to cost us money. We can't make money like that. I mean, we're going to get a bad reputation. We can't grow our volume. So nothing's more important than safety. The #1 thing, and we have to be safe before anything else. When I talk to the board of directors, by the way, and the executive team, I told them the same thing. I say, if you all think it's more important to focus on money, you're wrong. If you ain't safe, you're gonna get killed. You can't make no money killing people and cutting off the wrong leg. So I emphasize that to the employees, and I've also done that at the board of directors level. And just to make sure, if you all didn't know, I'm sure you already knew that, I also let you know. That's another thing I talk about with the employees, and it's pertinent for you all as well. So, we talk about the cost in terms of malpractice, and I explained that, once we cut off the wrong leg, we try not to drop a bill. So back in the old days, when you did stuff like that, the patient get a bill. Can you imagine you get a bill at your house and I didn't misdiagnose your breast cancer? What we do is we call finance and say, oh, don't drop a bill. Well, so what's happened? We've done the work, we've used the resources, and ain't nobody getting paid. We're gonna get sued, that's gonna come. But in addition, we usually get the people that were involved in that type of incident together, not to figure out who did wrong, but what went wrong. Because as I started with my talk, the first thing you remember, we promised Mrs. King and people like that we would do something to make sure it wouldn't happen again. And without getting people together to figure out what went wrong in the first place, we can't get that done. But my point is, when you look at the eyes, look into the eyes of people who are involved in those type of things, they look like that doctor I described to you earlier. When you're involved in an incident like that, you're shocked. And as you may, and you all probably already know this, nurses are more prone than any of us to quit behind those type of things. They are known to get out of nursing because they're so traumatized by doing that and hurting a human being. They just can't take it and they just quit. They're more so than anybody. Doctors, they take it a whole different way. They get, first of all, we get a little defensive and then we get kind of hurt, but we also feel that same guilt, but we're able to protect ourselves more because we got to keep going. We can't quit. Now getting sued, a whole different thing. That's traumatic to a physician. It seems quite personal. I've seen doctors threaten to quit when they go to lawsuits because I go with them when I'm in my capacity as VPMA, and first thing they say, this is crazy. I'm trying to help somebody, and they're gonna, how dare them? I'm gonna get out of medicine. And they go through that, but they usually recover, but it's traumatic for us as well. And so that's what we try to prevent and make things safer so we can all protect ourselves from the cost of that spiritual and emotional hurt that's more important than the money that we have to spend. The other thing I talk about right quickly is culture. I mentioned that to you all because culture means that we all act and do the same thing. So I can train, and I am training 2,400 employees because they work for us. And so do you all, but it's not mandatory. But if I train 2,400 employees in culture of safety and the doctor's like, well, it ain't got nothing to do with us, then we won't have a culture of safety. It would be impossible. I'll say, Dr. Reynolds, I'm trying to express my concern about you might be on the wrong side of the body. You telling me, hey, where'd you get your degree from? We can't have that kind of conversation because we're not safe. So that's why we put up the slide about culture, because I got to have the entire medical staff as well as all 2,400 employees involved in culture of safety. Then we talk about the components of a culture of safety, and I only focus on one thing. We did an assessment here at Methodist, and it was about our safety. How safe are we, and what do we think about how safe we are? And so we did that a couple of years ago, and compared ourselves to the state of Indiana. And in one particular question, it said, and this was for the employees, not for you all, say, do you feel safe reporting that you'd made an error to your supervisor without worrying about being fired or stuff like that? Do you feel safe in telling somebody that? We were last in the state of Indiana on that question. And so what I do, I emphasize to the employees, I say, let me tell you, the first people that heard this talk, first was the board of directors, then it was the executive team, and then it was the leaders, all the nurse managers, all the directors, because I need them to understand it ain't about you punishing nobody, because if you're gonna do that, they're not gonna tell us nothing. Why I'm gonna tell you if you're gonna fire me? And how are we gonna help and make things better if people are afraid to tell you when they made an error? And so that's why I started off with this. I want the employees to know that they're safe reporting that something went wrong and they made a mistake. Otherwise, we can't get nothing together. And so, and same for for you all as well. But clinicians, I don't know if you feel comfortable, but you should. If you don't, I used to tell the employees, I say the same thing. Then tell me, because that's I'm guaranteeing that you're going to be safe, because it's more important to have you be safe than just not to know something went wrong. Sometimes people, if you don't report it, then what's going to happen? It's going to happen to somebody else. Well, but why would you do that? I mean, that's just crazy. And so we want people to feel comfortable. So I'm trying to make sure our employees feel comfortable reporting if something goes wrong. Accountability, so that's just, I take a little time with accountability to say, okay, because when we think accountability in management anyway, and maybe I think nurses do that a lot, they think punishment. That means I'm going to discipline you. I'm holding you accountable. So why I explain to my audience and you as well is that you ain't children. And so I can't hold you accountable. You have to hold yourself accountable. Accountability means what? I can count on you, and you can count on me. And why I try to explain to my audience is that, okay, now if it turns out I can't count on you, well, then we're going to have a different conversation. But otherwise, I got to rely, because you're human, you're grown people, and you care enough to do the right thing that I'm not going to be looking behind you trying to hold you accountable. So then I go into so what we do with our employees, the whole point of this, and for you today, is for you to understand these 4 what we call behavioral-based expectations, for you to know them and for you to practice them, because if you do, it'll guarantee we'll reduce the likelihood that we're going to hurt somebody, kill somebody, or hurt one another in the job. So I'm just going to briefly go through what those are. So with the employees, after we have the didactic session that you're having with me right now, they break up into small groups and we go through, role playing and all that kind of stuff. But my high-priced intellectual physicians and allied health professionals, you don't need that, because most of the stuff you already know. So just by me just talking about the concepts, I think you'll readily see because it's intuitive to what you do as clinicians. But for them, it's more focused. So what you can expect to see, especially this group, because you're in the house so much, you're going to expect to see these employees exhibiting the behaviors I'm about to run by you. And you say, oh, they learned that from Dr. D. So if you ain't seen it, then I need for you all to help me and let me know that ain't happening, because it's very important that you see these behaviors. So before I go into the particular things that we teach them, I discuss a couple of things with them. I say, well, as human beings, we're prone to errors. That's just the way it's going to be. And I say, and also there's 3 particular errors that we're prone to that I want to discuss with them. And I say there's what we call a skill-based error, a rule-based error, and a knowledge-based error. And so after I describe to you what these errors are like, then we can teach you how to reduce the errors. That's why we talk about the errors themselves. So without going through every different slide, just very quickly, I'll say, well, skill-based error is where it's a skill. It's physical mostly. And you're so good at it, it becomes automatic. And for example, driving. And I described, I don't know about you all, but for me, you drive home, you drive to work, and then one day you drive home, you come into your house, and you think, you drive to your house, and you think, I don't remember nothing about that drive. I don't know about that. It's happened, like, because you're on autopilot, the same road, and so hopefully, you signal when you change lanes and you hit the brakes, but you get to the house, you're just like, oh, I'm home. And that's when and I said, well, when you're on autopilot, that's pretty safe because, 1 out of 1,000 times, something might go wrong on autopilot. But then I say, but if you were in autopilot and you're counting 5 sponges in the OR, and it's 4, then that's a problem, right? Isn't it? And so, and then I described that, well, and in fact, we had a case last year where that's what happened. So we had this guy had a sponge left into his belly, had to go back and get it out after a few days. He wasn't getting better, as you would imagine. Got a little fever. CT scan showed the sponge. And so we went through the medical record and we checked the sponge count, and it was absolutely correct sponge count. And I say, well, that's when you're on autopilot, and psychologically you said, okay, I count to 5 every day for all this time, and today it was 4. But your mind had already told you it's 5. And that's when you're on autopilot. So I tell them we're going to teach you some things that if you use these techniques, you won't be on autopilot, because autopilot might be one thing when you're driving home, and it's probably not that good, by the way, but it is a whole nother issue when you leave a sponge in somebody's body because you're counting 5 and it was really 4. And then I talk about rule-based errors. I say, so basically you have rules, and that's part of that Swiss cheese diagram. Part of the layers of things that protect our patients from damage are people following rules and policies. And so if you don't know the rule, or sometimes you make up your own rule, or you choose to ignore the rule, then things go wrong. And I usually ask my audience, I usually stick with the driving thing. I said, well, let me see, who looks like that? Let's take BJ. So when you approach a yellow light, what's the rule? Hey, slow down. And then I say, well, and what? And I say, well, not what you do, BJ, but what do you think Clive does when he approaches the yellow light? Of course, and that's basically saying, well, we know what the rule is, but I want to knock 10 seconds off my time getting home, so I'm going to speed through the yellow light. And I said, well, you know what? That's usually safe. Every once in a while, okay, you're going to get a ticket. There was a police officer you didn't see. Every once in a while, you're going to get blindsided because somebody else is running through a red light and you're going to have issues. But that ain't that often. But when it does happen, in healthcare, it's catastrophic, just like it can be in real life. And the last thing I discussed with them is a knowledge-based error or a knowledge-based activity. I say a knowledge-based situation where it's something that you've never done before, or it's something you've done before, but something about it is different than you ever seen before. And usually that's a situation where I stick with driving. I usually use me in this case. I say, you know what, I'm 60 years old now, but when I was 30 years old, I was not as wise as I am now, and I was kind of a foolish guy, And I would tell them about the time I went to Disney World, had my 2 kids and my wife. We went to Orlando, rented a car, and we got lost. And so my lovely wife says, Mike, why don't you go into a drive, to a gas station and ask for directions. Now I was a younger man then. And I'm like, I'm not going to ask no directions to nobody. And you're stupid. And so, and of course, I'm guessing, and we take the wrong road, and after a while, there wasn't no gas stations. And it was getting dark. And by this time, my lovely wife had a whole different tone and a whole different look. And so, that's when so I'm thinking, well, okay, first of all, they didn't teach me in med school how to get to the Disney World. So why do I think I can figure it out? Why would I not ask for directions? I'm going to guess. I'm going to figure it out because, I'm a doctor? No. So that's one thing to be a knucklehead when you're a young father, but when you're in medicine and you're trying to figure it out and you guessing, are you kidding me? But that's what people do. You know why they do it? Because sometimes the environment they're working in is not friendly. They say, well, hey, Dr. V, Dr. Abbas, I'm going to ask her a question. Well, wait a minute. Oh, well, you getting paid the same money I am. Don't ask me nothing. So you're scared to ask because it's not friendly. And in our hospital setting, that happens a lot because people are not welcome. And so, so instead of asking, because they don't feel comfortable asking, they start guessing and trying to figure things, and they hurt people. And so I try to explain to them, you know what, especially when it's a knowledge-based situation, don't you ever start guessing and trying to figure nothing out. Ask somebody, look up a reference. So I try to emphasize the importance of doing that. But then I end up, and I go through the different things and techniques that we teach them, all that you all are familiar with. So for the skill-based error, we teach them a technique called STAR. STAR stands for stop, think, act, and review. And so I use this, I use me again, because I've been known to walk out my house and leave my keys on the counter. Not cool. So now when I do it every day for my life, I open the door, before I step out, before I close the door, I stop, say, okay, I think, where's my keys? I feel for them, I do every day. I act, I close the door, I review, that went well. Takes about, 10 seconds to do that? But if you do that, you won't miscount the sponge. And you won't lock yourself out the house. And so we teach them that technique. And so you can expect to see them using that on the floors. We teach them about communication. We teach them to communicate by SBAR. So if you call Dr. Reynolds up and you got something wrong with your patient, make sure he knows exactly what the situation, give him situation, background, assessment, and make a recommendation. Clinicians like that, right? Say, well, nurse, what do you think? Tell the doctor, tell the allied professional, what do you think? So they'll know, hey, you better come down right now because I think it's urgent. Tell them what you see. So that's how we ask our nurses to communicate with you all, and vice versa. And that's what you should expect to hear from them, because Shelley's been emphasizing SBAR. You call the hospitalist, you call a doctor, use that type of communication, because that will keep everything safe. Then we do a questioning attitude, and that's QVMV. That stands for question, validate, and verify. It's simple. If something looks funny, well, then you might want to give it a second thought. And so what happens in healthcare, sometimes it'll look funny. I say, man, there's just something ain't quite right with that. And people say, that's all right. When I was in my previous hospital, we had a situation where this patient was a stroke patient. And this patient had a feeding tube and hadn't eaten for years. But they called the doctor for some orders at 2, 3 o'clock in the morning, and when you sleep, sometimes you don't get everything right, and so the doctor ordered a regular diet for this patient who clearly couldn't eat because they were going to aspirate. We knew that. And so the next day, everybody walked, the nurse walked in the room, and the dietitian walked in there, and this patient clearly common sense would tell you they can't eat a regular diet, but they brought a tray, and people walked in the room, and nobody thought anything funny about what they were saying. And you know what happened. That patient ate and aspirated. And so when the doctor, I remember she saying, well, geez, I was sleepy and I made a mistake, but why didn't you say something? Well, I don't know. Maybe they were, maybe this doctor was intimidating in some way, but I think what it was, nobody was even thinking. Nobody had her back. And that's all she was saying, why didn't you have my back? So we teach our employees, be thinking. Don't be thinking about what's happening at home. Think about what's happening right here and be paying attention, because that's what we need from you, for you to pay attention. We'll have a questioning attitude. Then the last thing we teach them is called never leave your wingman. We teach them a technique called peer coaching. So never leave your wingman just simply means having somebody's back, making sure everything's clear so they can take care of business, right? That's what, And so I described to them, well, sometimes talking to your peer when you're trying to help them can be difficult because they take it the wrong way. And how about if you're trying to talk to somebody who's considered your superior? The classic nurse-doctor relationship, correct? Or it could be allied health professional-doctor relationship. And so I described to them, this is what's happened recently. And we had a doctor, he was putting in a chest tube, patient had a pneumothorax on the right side. Chest x-ray was up on the board and the whole deal. He's going into the left side. So the nurse said, doc, you're on the wrong side of the body. This patient got the disease on the right side. So, he got the attitude with, who are you to tell me? What medical school did you go to? And he proceeds to put the chest tube on the left side and collapses the only good lung the patient had, right? And so when I'm talking to the employees, I'm saying, well, okay, now I can see that's a difficult conversation. You tried to help that doctor. That doctor was knuckleheaded, which is why we want to talk to the doctor so you all don't be knuckleheads, right? When the nurse is trying to help you, respect your colleagues. But he didn't, because he's old school. How you gonna tell me, well, you put the tube in the wrong side and collapsed the lung, knucklehead? We don't want that to happen. But having that conversation, so the next time the nurse is not gonna be likely to even try to challenge the doctor, is she? Because she's gonna be scared. And so we teach them a way to approach the physician in a certain way that they'll be more receptive to the conversation, and how to approach each other so they'll be receptive to the colleagues. Because it really is a certain technique, and it's called peer coaching. We teach them a particular technique. But it's really simple. You know what? You want to make sure you're respectful, acknowledge that, hey, I just want to point something out, ask a few questions, Doc, what do you think? And if you have to, though, when you get that kind of response, then you say, Doc, I'm very concerned. I'm going to have to call somebody about this. Mark is about to do something crazy. I'm going to call Dr. Reynolds on you. You got to do, and when I teach the employees, say, you know what? We can teach you the techniques of how to have that communication, but we can't teach you what it really takes to have that in the first place is the courage. So you got to be thinking, I'm going to threaten Dr. Washington here. I'm not really threatening him. I'm trying to be nice. But I'm going to call the medical director because he's about to hurt a patient. Now, he might get mad at me, so I get to weigh Dr. Washington being angry with me and me not letting him hurt somebody, because he really don't want to do that, by the way. Later on, he'll say, nurse, I was tripping. I am so glad you called Dr. Reynolds on me, right? Hopefully that's what he's going to say. Now, as you might not be surprised, back in the day when we first started doing cultural safety, doctors weren't necessarily grateful when they those things were pointed out. They would still be angry, even though they were prevented from doing wrong-sided surgery. That's how knuckleheaded we can be sometimes as professionals. I don't know about you all, but I have plenty of courage. Before I let Mark hurt somebody, I'll take him out. Ain't gonna happen. Because I ain't scared of nobody when it comes to that patient in front of me. So I try to teach employees, you gotta make a decision. Are you more concerned about that life of that patient in front of you, or some doctor or some allied health professional copying an attitude? So I can't teach you and give you courage. You gotta have that on your own because you care. But then we teach them how to approach you properly with that conversation. So once again, we spend time with you all so that you will be receptive to those conversations, because I'm telling my nurses and all our clinicians, ask our doctors a second time. Say, Doc, was that 15 milligrams or 50? Did you say 1.5 or was that 5.0? Tell Doc, Jessica, thanks for those orders. Let me repeat back what you just said. And I expect Jessica to say, absolutely, because I'm not going to hang up until you tell me. But we're not getting that, but I'm telling you, insist on that. Because all you're trying to do is make sure that we're safe and we're helping and working together so we can reduce the likelihood that we'll hurt or kill somebody in our organization. So that's usually concludes the conversation, the lecture for the employees, and then they break up into small group sessions and we teach them with role playing and all that kind of stuff. But once again, for this outstanding intellectual group here, I think you're kind of familiar with the concept. I know that you are. They're intuitive and they're part of what you learn in your training. But now you know and you can expect and be looking for these type of behaviors from our employees. And once again, from this point on, we'll be taking it to all the other 400 physicians on our medical staff. So with that, I thank you. Gotta go.